Hmm. Hello. Sir, good afternoon.
Good afternoon, sir.
Good afternoon.
Welcome, sir. Welcome, Dr. Shalya, sir.
Namaskar, sir.
Namaskar, namaskar.
Can I share the screen so that it will be...
Very good afternoon, all of you.
Good afternoon, Shrikant.
Very good afternoon, all of you. Very good afternoon, all of you. I am Dr. Shrikant Hadole, Organizing Secretary and Assistant Professor of Department of Dravya Gun Vigyan, Jupiter Ayurved College. I herewith welcome you all on this national webinar on Shalya tantra, organized by Jupiter Ayurved Medical College, Nagpur. First of all, I would like to wish you all a very happy World Environment Day. Before proceeding towards the session, I would like to request all of you to join us for the Lord Dhanvantari Stavan. I'm just sharing the video. Just a moment.
थोडं माझं
Agrawal sir, good afternoon.
Sir, good afternoon. Dr. Agrawal, sir, good afternoon,
Good
sir.
afternoon. Good afternoon, Nanda
Yes,
sir.
good afternoon to everyone.
Page sir.
Good afternoon. Good afternoon.
Ave sir, good afternoon.
Good afternoon.
Prashant sir, good afternoon.
Very good afternoon, sir.
Good afternoon. I request, please confirm whether my screen is visible or not.
Yes, visible.
So let us join together for Lord Dhanvantari Stavan. Please confirm whether it is audible and visible or not.
Yes, please.
नमामि धन्वन्तरीरादिदेवं सुरासुरवन्दितपादपद्मं लोके जरारुक् भयमृत्युनाशं दातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां दधतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यांशुक परिविलसन् मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसच्चारु पीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढदावाग्निलीलं प्रौढदावाग्निलीलं प्रौढदावाग्निलीलम्.
I wish Lord Dhanvantari to bless us all with health, wealth, and prosperity. Now, I would like to request our respected Principal Dr. Subhash Wage sir to please welcome all the dignitaries and for the welcome note. Over to you, Dr. Subhash Wage sir, for welcome note.
Thank you, Shrikant sir. Very good afternoon to one and all, and I welcome you all the participants, dignitaries. The basic idea behind this conducting national webinar was, Dr. Shrikant sir, may I request you to shut down that noise?
Okay. Yes, sir. Sure, sir.
Can you unmute it?
Please proceed, sir.
Listen. The basic idea behind this particular national webinar on surgery was to create the interest, and not only to create the interest, but to impart the practical training to the participants. And if any one of the participant is interested in pursuing it further, they may contact our speakers further and get acquainted themselves with this skill. And we want to bring out the skill-oriented army of the surgeons, those who will restore our pride, and those who will practice efficiently, and those who can serve the society. So this is the basic intention behind conducting this national webinar. We have mainly focused on the practical approach of the surgery, and hopefully today's webinar will arouse interest and create awareness about the practical surgery, and it will help in bringing out the skilled surgeons. So thanking you. Over to you, Shrikant sir, for further proceedings.
Thank you very much, respected principal sir, for your vision and inspiring us all the time for such wonderful events. हमारी संस्कृति अनुसार किसी भी शुभ कार्य की शुरुआत सर्वप्रथम हम भगवान समान अतिथि गण के स्वागत से करते हैं एवं उनकी स्तुति वचनों से करते हैं। अतिथि देवो भव, इसी प्रथा को आगे बढ़ाते हुए मैं सर्वप्रथम आज के इस विशेष कार्यक्रम के प्रमुख अतिथि डॉक्टर आशुतोष गुप्ता सर, जो महाराष्ट्र काउंसिल ऑफ इंडियन मेडिसिन मुंबई के अध्यक्ष पद पर कार्यरत हैं, उनका समस्त जुपिटर परिवार की ओर से तहे दिल से स्वागत करता हूं। आदरणीय आशुतोष गुप्ता सर का परिचय देना यानी सूर्य को आईना दिखाने समान होगा। आज के इस नेशनल वेबिनार के उपलक्ष्य पर मैं सम्माननीय डॉक्टर आशुतोष गुप्ता सर जी से निवेदन करता हूं कि वह अध्यक्षीय उद्बोधन पर हमारा मार्गदर्शन करें।
हिंदी में बोलना है, मराठीत बोलूं?
हिंदी में सर।
जी। मेरा आवाज सुनाई दे रहा है आपको?
यस सर, प्लीज गो अहेड।
जुपिटर आयुर्वेद महाविद्यालय ने आयोजित किए हुए इस नेशनल वेबिनार, जो कि शल्य तंत्र पर विशेष रूप में है, इस वेबिनार के उद्घाटन के अवसर पर यहाँ पर उपस्थित प्रमुख अति विशिष्ट अतिथि हमारे गुरु डॉक्टर श्रीकांत देशमुख सर, MUHS के ऑब्जर्वर डॉक्टर महेंद्र अग्रवाल जी, अपने कॉलेज के प्रिंसिपल डॉक्टर सुभाष वाघे जी, प्रवीण सहावे जी, प्रमेय धगे जी और सभी मान्यवर अतिथि तथा इस वेबिनार में सम्मिलित सभी आयुर्वेद के अनंत काल के छात्रगण। शिक्षा ये एक निरंतर चलने वाली प्रक्रिया होती है और स्वास्थ्य शिक्षा क्षेत्र में तो शिक्षा की निरंतरता कितनी प्रासंगिक है, ये पिछले 2 सालों में हम अनुभव करते आ रहे हैं। और इस निरंतरता को ध्यान में रखते हुए वेबिनार के माध्यम से शल्य के प्राचीन शास्त्र को नित्य नूतन विकास के आधार पर जोड़ने का काम करना ये बहुत आवश्यक है। शल्य में हम देखते हैं कि जो पुरानी बातें थी, जैसे पिपली का चींटी से हम कभी स्टिच देते थे और आज कैटगट हम इस्तेमाल करते हैं, तो नई नई चीजें जो टेक्नोलॉजिकल एडवांसेस है ये रोज आती जाती है, और उसका अंतर्भाव करके हम रुग्णों को अच्छी सेवा सुविधा और शुश्रूषा कैसी कर सकते हैं, इस दृष्टि से हमारा विकास, हमारा सर्जन की दृष्टि से विकास, शल्यकर्मा के दृष्टि से विकास, इस अवसर पर आपने जो ये वेबिनार आयोजित किया है इसमें अच्छी भूमिका निभाएगा ऐसा मुझे विश्वास है। और विशेषतः सेंट्रल काउंसिल ऑफ इंडियन मेडिसिन ने पीछे जो गैजेट नोटिफिकेशन निकाला है शल्य और शालाक्य तंत्र विषय में, इसके परिप्रेक्ष्य में तो इसकी प्रासंगिकता बहुत ज्यादा बढ़ जाती है ऐसा मेरा मानना है, क्योंकि हम पर बहुत सारी क्रिटिसिज्म होता है कि आप क्या करते हो, अंग्रेजी सर्जरी को सिर्फ संस्कृतोद्भव नामों के साथ जोड़कर आप क्वैकरी कर रहे हो, ऐसी काफी हमको जिसको कहते हैं टीकाओं के बाण सहने पड़ते हैं। लेकिन हमारे शास्त्रों में इन सब चीजों का कितना उल्लेख है और कितना सूक्ष्मता के साथ प्रिंसिपली उसका वर्णन हमारे ग्रंथों में किया गया है, इसको ध्यान में रखने के लिए पहले शास्त्रार्थ जानना हमारे सभी के लिए बहुत आवश्यक है। और शास्त्रार्थ जानकर, रीडिंग बिटवीन द लाइंस पढ़कर, नई जो कुछ तकनीकी विकास हुआ है उसका अंतर्भाव हमारे प्रैक्टिस में करना बहुत जरूरी है। जैसे लेप्रोस्कोपिक प्रोसीजर्स होंगी और काफी एडवांसेस सर्जरी में, मैं तो संहिता का छात्र हूं तो मैं सर्जरी के बारे में बहुत ज्यादा बताने का अधिकारी हूं नहीं, लेकिन जितना मुझे कॉमन सेंस के रूप में समझ में आता है तो इन सभी विकास जो कुछ हुआ है, और ये विकास केवल एलोपैथी शास्त्र का नहीं है, तो ये विकास कहीं ना कहीं फिजिक्स का है, कहीं ना कहीं बायोकेमिस्ट्री का है, कहीं ना कहीं और बाकी कुछ विज्ञान की विधाओं का है। तो ये विकास पर केवल एलोपैथी या पाश्चात्य मेडिसिन जो है इनका कोई मोनोपोली नहीं है, इसका अधिकारी हम भी उतने हैं जो है। तो इसको बड़े ही के साथ शास्त्रों मूलभूत सिद्धांत है, शास्त्र के जो मूलभूत तत्व है उनको धक्का न पहुंचते हुए, उनको बाधा न पहुंचते हुए इन सभी का अंगीकार करके इस चिर पुरातन शास्त्र को नित्य नूतन आविष्कारों की संगति देकर विकसित करने में आज का ये वेबिनार अच्छी भूमिका निभाए, इसी कामना के साथ, इसी मंगल कामना के साथ आप सभी को शुभकामना देते हुए अपने शब्दों को विराम देता हूं। बहुत बहुत धन्यवाद।
अत्यंत धन्यवाद सर, मैं आपका बहुत बहुत आभारी हूँ। आपने अत्यंत अल्प समय में हमारे इस कार्यक्रम को काउंसिल की मान्यता देकर इस विशेष अवसर पर प्रमुख अतिथि का स्थान ग्रहण किया। इसके लिए मैं हमारे संपूर्ण जुपिटर परिवार की ओर से आपका अत्यंत आभार व्यक्त करते हैं। धन्यवाद सर। अब इस कार्यक्रम के विशेष सम्माननीय अतिथि महाराष्ट्र आरोग्य विज्ञान विद्यापीठ नासिक के आयुर्वेद विभाग के फैकल्टी डीन एवं PSMSS आयुर्वेद कॉलेज के प्राचार्य डॉक्टर श्रीकांत देशमुख सर का मैं समस्त जुपिटर परिवार की तरफ से स्वागत करता हूँ। सम्माननीय देशमुख सर सुनाम धन्य एवं सर्वश्रुत व्यक्तिमत्व, किसी परिचय के मोहताज नहीं। मैं उनसे अनुरोध करता हूँ कि वह आशीर्वाद पर वचनों से हमें अनुग्रहित करें। देशमुख सर।
नमस्ते। Am I audible?
Yes sir, please go ahead.
Thank you. Jupiter Ayurved Medical College and Hospital Nagpur has organized this national webinar on Shalya tantra, especially on proctology and laparoscopy. It is a nice thing because recently during this pandemic situation, a lot of webinars are being arranged and are very helpful for our Ayurved fraternity. Today's webinar is a national type of webinar, and it is also organized in collaboration with the Maharashtra Council of Indian Medicine, Bombay. and Maharashtra University of Health Sciences, Nashik. I would like to congratulate management of this institution, especially Mrs. Tarini Nikhare Madam for giving opportunity to the staff and principal of this institution, as well as promoting such activities for the spread of Ayurveda as a science and technology. So this is the activity which is being organized by the principal, uh, Dr. Subhash Wage sir. Under his leadership, all the department heads, they have taken efforts to organize this and to come to this moment. So I would like to first of all congratulate from our side of Maharashtra University of Health Sciences as well as from MCI to this institution. Today's chief guest, Dr. Ashutosh Ji Gupta sir. He is the chief of our regulatory body, which is regulating to the Maharashtra state, especially through the Maharashtra Council of Medicine. And he has worked tremendously and made a lot of change in the work functioning of MCN. And lot of transparencies he has made. He is of best friend of mine, and he is working in our university platform as a senator, and his contribution is much more in the university working also. And also he has worked in the our FRA, that is the Fees Regulating Authority also, and that is helped a lot to our private institutions in all over Maharashtra while framing the tuition fees and all. So it is his contribution, and I wish him every success in future also. And he is chief guest for today's function. Is also a feather in crown of this institution. Also, I would like to congratulate my friend Dr. Mahendra Agrawal ji. He is the observer from university side. He is my colleague in the university. Recently, we have arranged some meetings. His contribution is also good, and he is today's observer. And this is also a good thing for today's webinar. So just now, Dr. Ashutosh ji mentioned that this Shalya department has got a special, I think we can call it as a Rajashray. So every time it is required to get the some recognition from the our regulatory bodies like Ayush, Ministry of Ayush, central government. This gazette which was published recently has given a special equivalence with the surgeons. So it becomes the responsibility of all surgery people of our whole India that they can contribute as equal to the modern people. So Dr. Wagesar's view is that the central government, they are promoting Ayurveda as a health science, and it is equivalent to the modern science also. So our Shalya people, our Shalakya people, it is the skill job, and they have to develop their skills along with the knowledge. So this webinar will contribute as a skill development program and knowledge development program, and it will increase the interest and awareness in the Shalya people. So there must be Shalya teachers also, Shalya related PGs and PhD scholars. So it is our responsibility to come up with the equivalence with the modern people, and we show our ability. We are not less than modern people, because already our people are contributing in proctology and all types of surgery all over India. So the name of Maharashtra state is always ahead in as compared to the other states as far as the surgery and ENT operative procedures are concerned. So I wish every success to this webinar, and I would like to congratulate to the Shalya department also, teachers, professors and readers from the Shalya department for arranging this type of webinar. and this should not stop here. So skill development, it's always important in the surgery, because PJ Deshpande sir used to do the surgery, dropless surgery, and here his followers also used to do like that surgeries. I know so many people from the BHU also, because he made everything as compared to he was the international figure, and he has made our footprints for us to follow it. So everybody's responsibility is that he to continue his name and his pathway, and achieve the goals Mr. PG Deshpande sir. So once again, I would like to congratulate Dr. Wage sir and his team, and to the institution, and all my dear friends. Thank you very much, and best luck.
Thank you very much, Deshmukh sir, for your kind words. I would like to specially thank you for endorsing this event on behalf of MUHS University and accepting our invitation for being on the post of guest of honor. Thank you very much, sir, again. अब मैं हमारे महाविद्यालय के सम्माननीय सचिवा महोदय श्रीमती तारिणी मैडम से निवेदन करता हूं कि वह शुभेच्छा संदेश प्रदान करें। तारिणी मैडम, हम आपसे अनुरोध करते हैं कि कृपया शुभेच्छा संदेश प्रदान करें।
Dr. Shrikant sir, may I intervene a little bit? Tarini madam is getting a problem in getting connectivity.
Okay, sir.
Till she joins this webinar, we can proceed further.
Okay, sir. So I would like to proceed further. इस श्रृंखला को आगे बढ़ाते हुए मैं हमारे अन्य अतिथि डॉक्टर महेंद्र अग्रवाल सर जी को, जो हमारे साथ एज ए MUHS ऑब्जर्वर जुड़े हुए हैं, उनका समस्त जुपिटर परिवार की ओर से स्वागत करता हूं। डॉक्टर महेंद्र अग्रवाल सर नागपुर के भाऊसाहेब मुळक आयुर्वेद कॉलेज नंदनवन में काय चिकित्सा विभाग में विभाग प्रमुख एवं प्रोफेसर के पद पर कार्यरत हैं। मैं डॉक्टर अग्रवाल सर से निवेदन करता हूं कि वह हमारा मार्गदर्शन करें।
नमस्कार। ज्युपिटर आयुर्वेद मेडिकल कॉलेज नागपूरच्या वतीने आयोजित नॅशनल वेबिनार और सर्जरी करता आजचे चीफ गेस्ट माननीय डॉक्टर आशुतोष गुप्ता सर, प्रेसिडेंट MCI मुंबई, गेस्ट ऑफ ऑनर माननीय डॉक्टर श्रीकांत देशमुख सर, फॅकल्टी डीन ऑफ आयुर्वेदा MHS नाशिक, ज्युपिटर आयुर्वेद मेडिकलचे प्राचार्य डॉक्टर सुभाष वागे सर, सेक्रेटरी मॅडम श्रीमती तारिणी निघारे मॅडम, उपप्राचार्य डॉक्टर सुंदर सिंग डंगा सर, ऑर्गनायझिंग कमिटी मेंबर, तसेच आजचे गेस्ट लेक्चरर माननीय डॉक्टर प्रवीण साळवे सर, डॉक्टर प्रमेय ढगे सर, टीचिंग स्टाफ ज्युपिटर कॉलेज, स्टुडंट आणि वेबिनारला उपस्थित सन्माननीय सदस्य यांना माझा नमस्कार। महाविद्यालयाने शल्यतंत्र विषयावर नॅशनल वेबिनारचे आयोजन केले, त्याला MUHS नाशिक विद्यापीठाने मान्यता प्रदान केली। त्याकरिता मी MUHS नाशिक विद्यापीठाचे रजिस्ट्रार माननीय डॉक्टर KD चव्हाण सर, तसेच आमचे फॅकल्टी डीन माननीय डॉक्टर श्रीकांत देशमुख सर यांचे आभार मानतो। निरंतर वैद्यकीय शिक्षण ही काळाची गरज असून आयुर्वेद शिक्षण पद्धतीमध्ये ते सर्वांकरता उपयुक्त ठरते। सध्याच्या कोरोना सारख्या साथीच्या आजारांमध्ये हे सेमिनार ऑनलाईन घेण्यात येत आहे। महाविद्यालयाने विविध विषयावर या महिन्यामध्ये नॅशनल वेबिनारचे आयोजन केले आहे। यामध्ये नामवंत वैद्यकीय चिकित्सक आपले व्याख्यान देणार आहे। माझे सर्वांस निवेदन आहे की त्यांनी या वेबिनारचा आपल्या ज्ञानवर्धनासाठी लाभ घ्यावा, जेणेकरून सर्व वैद्यांना आपल्या आरोग्य सेवेमध्ये अधिक कौशल्यपूर्ण सेवा देता येईल। मी पुनश्च एकदा महाविद्यालयाच्या सेक्रेटरी श्रीमती तारिणी निघारे मॅडम, प्राचार्य डॉक्टर सुभाष वागे सर, तसेच ऑर्गनायझिंग कमिटी मेंबर यांना आयोजनाबद्दल हार्दिक शुभेच्छा देतो व मला 2 शब्द बोलण्याची संधी दिली त्याबद्दल आभार व्यक्त करतो। धन्यवाद। Over to you, sir.
Thank you very much, sir. Thank you very much. Now I would like to thank all the respected chief guests Now I would like to request the professor and HOD from the Department of Shalya Tantra to invite and introduce our first guest speaker. Over to you, Dr. Veena Kulkarni, madam.
Thank you, Hadore sir. Very good afternoon, and I welcome to all of you in the today's national webinar on role of laser therapy in the management of proctology disorders with case presentations, conducted by Shalya Department of Jupiter Ayurvedic College and Hospital, Nagpur. I wish you all the happy International Environment Day. I have pleasure to introduce today's chief guest of this webinar, Dr. Praveen Sahave sir, for the session first. Dr. Sahave brought up in Buldhana from small district of Vidarbha region. After completed his basic education, he got the BMS degree from SG Ayurved College, Mozri, Amravati district, and got postgraduate degree from Government Ayurved College, Nagpur. After completion of his post-graduation, he joined as associate professor at CG Ayurved College, Rajnandgaon, Chhattisgarh, for few years. He had also worked as secretary of NIMA Proctology Nagpur and is life member of NIMA. Friends, Dr. Sahave sir has always promoted the knowledge of Ayurveda in the society and adopted the modern technology of BIEM and laser. He had taken the training on BIEM and laser technology from Zhengzhou, China, and spread it in India. Dr. Praveen Sahave sir has conducted so many health and surgery camps for poor and needy people in the society. He has up till now conducted near about 5,000 surgeries at free of cost. Dr. Sahave was awarded with various local, state, and national awards. To name some of them are Sushrut Award for Extraordinary Work in Proctology, Excellence in Laser Technology, Sakal Excellence Award, Best Piles Laser Surgeon of Maharashtra and Young Outstanding Laser Surgeon of Maharashtra, Best Ayurved Surgeon of India Award, Delhi. National Zero Miles Award, Times Healthcare Achiever Award, Mahamitra Puraskar, Buldhana Bhushan Award, and Samaj Bhushan Award. Dr. Sahave also participated in TV shows on health conducted by TV channels Awaz India, News 18 Lokmat, Lord Buddha, and UCN channel. This is brief introduction of Dr. Sahave sir, and I request him to guide us. Over to you, sir.
Thank you, ma'am, for a long introduction. And am I audible and visible?
Yes, sir. Please go ahead.
Okay. First of all, respected dignitaries, MCM President Dr. Gupta sir, respected Mahendra Agrawal sir, Principal Dr. Waghe sir, Dr. Deshmukh sir, and all. Today's my topic is role of laser therapy in management of proctological disorders. So I am in front of you with these blessings of my parents, my respected guide, Dr. Subhas Raut sir, HOD and Dean of Government Ayurved College, Nagpur, and my laser beam guru, Dr. Shi from Zhengzhou, China. The country China is known to everyone, every world due to COVID now. So these are some snaps with my guru, Dr. Shi, who has taught me the basic of laser and beam. So awards are like hemorrhoids. Sooner or later, everyone also gets one. It is called by Sarah Morton. जीवन में अवार्ड्स किसी को पहले मिलेंगे, किसी को बाद में मिलेंगे, वैसे ही हेमोराइड्स का है, किसी को पहले हो गए, किसी को बाद में हो गए। ये ग्रेट साइंटिस्ट सलाम वाटर ने कहा है और प्रोक्टोलॉजी की देन है, हमारे गुरु की देन है। We have reached up to 31 of national and regional awards. So these are some awards. So basically, what is mean by laser? Though the CBSE exam of 12th is cancelled, but we are all has gone through the physics in 12th. So again, we are going for few seconds or few minutes in physics. What is the basic of laser? Laser means laser light application by stimulated emission of radiation. So in 1917, Albert Einstein lays the foundation of laser technology as a stimulated emission, and in 1959, Dr. Jordan proposes that the stimulated emission can be used to amplify the light, and it is called as a laser. In 1963, carbon dioxide, that is CO2 laser, was first developed by Kumar Patel at NT Labs, and CO2 laser was most costlier laser that time, and it was used in medical field. What is laser wavelength? The distance from one wave crest to another wave crest is called as wavelength. There are different electromagnetic spectrum in nanometer for TV, NDR, diode, X-rays, microwaves, etc. We are using diode laser. So particularly we are using 980 nanometer diode laser and 1470 nanometer diode laser. We'll discuss in detail. So what is difference between light and laser? White light and laser. Difference in laser, it is a coherent, it is in synchronitic phase, and white light is non-coherent. Laser is having a monochromatic, means it is having a specific color, and light is not having a specific color. It is a collimated. Laser can be collimated, means it can be focused on particular things, and light cannot be collimated. So laser light is measured in nanometers. Nanometers is equal to 10 raised to minus 9 meters. We have seen collimated means very directional, can be focused. Coherent means very synchronized phase, and monochromatic means very precise color. There are different wavelength of lasers in markets, and in proctology and in general surgery we are using 980 and 1470 diode laser. Why we use 1470 nanometer wavelength? It is the topmost and the highest wavelength in the proctology and in general surgical device. The comparison between 918 and 1417 is that 980 nanometer absorption coefficient is very higher for hemoglobin than water. And unlikely in 980 nanometer radiation, endovenous laser treatment needs appropriate power, that is 10 to 12 watt for the treatment, while in 1417 nanometer radiation needs smaller, that is 5 to 8 watt of energy. So the lower the energy, significantly lower the adverse effects. So we are using 1470 nanometer laser wavelength. So the depth of penetration in water is 2 centimeter by 980 machines, and in depth of penetration in hemoglobin is 0.05 centimeter. While that of is 1470, it is 0.03 centimeter. So why we choose 1470 nanometer wavelength? The vein structure is mostly a water soluble, and 1470 nanometer wavelength laser is specific for targeting water at its chromophore to absorb the laser energy. The optimal depth of penetration is water is 0.03 centimeter, and resulting is optimum vein ablation, and laser energy is preferentially absorbed in the intracellular wall of the vein wall and in the water content of the blood. So the irreversible photothermal damage is very less, and with the 1470 nanometer, and there is a complete occlusion of the treated veins. So the pathophysiology of the hemorrhoids is completely gone. So there is no risk of damage to the surrounding tissue, and less depth of penetration adds safety to the elements. So we are using 1470. Energy, laser energy is joule, unit of energy is joule, watt is unit of power. 1 watt is equal to 1 joule for 1 second, and power density is watts divided by centimeter square. Smaller the focal spot, higher the power density. So the tissue effect of laser is to get an overall effect on the tissues, the following factors come into play: the power density, which earlier we had discussed, cooling, duration of exposure, specific wavelength, emission mode, and tissue characteristic. So the thermal threshold at 37 to 50 degrees Celsius, there is a hyperthermia at the tissue. At 60 degrees, there is a coagulation. At 70 to 90 degrees, there is a welding of the tissue. At 100 to 150 degrees, there is a tissue volatilization. And 100 degrees and up, there is a carbonization, tearing, and the blackening of the tissue. So what is the laser machine or the laser device? It is the laser component which is having resonant cavity, laser medium, it is semiconductor. One is having reflective mirror and another is partial reflective mirror, and there is one source of energy device. So this is the basic component of the laser. So diode, we are using 980 and 1470 diode lasers. The 532 nanometer, 635 nanometers, these are used in dentistry and other skin treatment. So active medium is solid semiconductor, electromagnetic spectrum is near infrared or invisible, and absorption characteristic is in melanin, hemoglobin, and water. So diode laser, it is delivered to the optic fiber. Mode is continuous or the pulse wave. IVR to protect the damage to the lens and retina while during the procedure. And applications, it is used in medical, dental, and always in cosmetic, gynecology, or other surgeries also. So why diode laser? It is FDA approved, and technically it is very better patient care, and technically solid state stable diode laser, and very reliable and simple to maintain as portable. It is 2.5 kg weight machine, and we can easily take it for outside. So hemorrhoids, before going to hemorrhoids is known in movies also. This is bodyguard movie scene, funny scene in movies. Another funny scene in one ad also. So we can see the first station of the hemorrhoid patient for difficulty in seating and all. So hemorrhoids means there are natural hemorrhoidal flexures in human, that is right anterior and right posterior and left lateral, and these flexures are the normal part of the anatomy and of every individual, and they plays an important role in protecting the mucosa of anal canal and prevent the incontinence. So surgical anatomy of the hemorrhoids, that is praise muscle, that is suspensory muscle which displaces towards downwards, and normally it contributes not only for the circulation of the area but maintain the continence by keeping the anal canal closed tightly. The symptoms of the hemorrhoids disease are known to everyone, that is including bleeding, splash of pan bleeding, itching, pain, and presence of lump in the anus. So hemorrhoidal cushion is nothing but it is made up of the connective tissue and sinusoid vessel shunt between arteries and vessels. So types of hemorrhoids, we know external hemorrhoids and internal hemorrhoids. External hemorrhoids are above the anus, and internal hemorrhoids are situated, we can see here, internal hemorrhoids at the base of the at the anal canal, inside the anal canal at the dentate line, and we can see how the hemorrhoidal pathology occurs. Am I visible and audible?
Yes, sir. Yes, yes.
Yes, you can see the ficus movement, how innocent ficus is traveling from the rectum to the anus, and due to the inflamed hemorrhoidal bile mass, see the expression of the ficus, how innocent the ficus is, and finally gets out and relax, and the bleeding occurs after the defecation, and that is a splash of bleed. So basically we are treating the cause of the hemorrhoid with the laser. So there are different causes: irregularity, childbirth, post-pregnancy due to CA, and other underlying diseases also for the hemorrhoids. So pathophysiology of the hemorrhoid is very important for treating by any method, whether you are using laser or any method, conventional also. There is an insufficiency of the wall mechanism in arterial venous shunt. There is a defect in the blood transportation in venous bloodstream, causing enlargement of the nodes, causing weakness of the elastic support and muscle tissue descends towards anus, and causing hemorrhoids. This is the basic cause. There are 4 grades of hemorrhoids. One grade 1 hemorrhoid is only bleeding there. Grade 2 hemorrhoids, the hemorrhoids comes out and goes automatically. Grade 3 hemorrhoids comes out during defecation and needs manual replication. And grade 4 hemorrhoid remains permanently outside. So laser hemorrhoidoplasty is the novel step and painless procedure worldwide. It is used, and the several studies and ranges from 2.9 to 50%. And many of these patients develop symptoms. 20 to 30% of will take advice from the colorectal surgeon or the proctologist. And the disease varies between common in 45 to 65 years of old. So, what is the mechanism of LHP? LHP means laser hemorrhoidoplasty, the procedure for hemorrhoids, laser hemorrhoidal procedures. There is a fibrous reaction in the endothelial and connective tissue when we induce the laser energy at the base of hemorrhoid pile mass, which causes narrowing or the closure of the blood vessels, causing depletion and drying effect, which automatically pulls the hemorrhoidal pile mass to the normal position, hemorrhoidal cushion position, and which retracts and fixation to the anal canal, and the pathology of the hemorrhoid pile mass completely goes off. So the procedure of laser hemorrhoidoplasty is the probe is introduced through the anal prolapse under the surface of the anoderm and inserted to the submucosal space till 2 cm above the dentate line or hemorrhoidal cushion. The laser is set for 7 to 8 watts and single pulse of 3-second duration is set, and energy is delivered in single shots for 3 seconds. During each shot, the probe has held in a position while being gently rotated around the axis to ensure the uniform application of light and prevent the adherence to the tissue. We'll see in the video in next slide also. So special probe containing the bare fiber is used. Here for hemorrhoidoplasty, we use a bare fiber or conical fiber, and for fistula, we use a radial fiber. So the probe is transferred through a special metal cannula. We'll see in the animation and then live video. This is animation for the laser hemorrhoidoplasty. You can see the laser treatment here. This is a internal hemorrhoid. We are introducing a proctoscope, and then we are giving energy at the base. This is bare fiber which we used, or the conical fiber for hemorrhoids, and radial fiber is used for fistula. There is no need of any stitch. There is very less minimum bleed, and procedure is daycare procedure. So you can see the live procedure. It's a grade 2 hemorrhoid pile mass at 3 o'clock, and we are introducing the cannula at the base of the hemorrhoid. We are giving energy to the pile mass, and the basic for giving energy is, I will show in the next video what we do. The setting is hardly the procedure takes 1 to 2 minutes, and the complete procedure takes 8 to 10 minutes. This is another patient having grade 2 piles and bleeding, and we did hemorrhoidoplasty. We are inserting the metal cannula at mucocutaneous junction up to the base of the hemorrhoid. Before doing this, we give 60 joule of energy without touching to the hemorrhoid pile mass, and then 70 joule in the hemorrhoidal complex, and below that 80 joule of energies. So total 200 joule of energy for hemorrhoid pile mass, one hemorrhoid pile mass, depending on the size and stage of the hemorrhoid pile mass. On table 60% reduction is only sufficient. Only 60% reduction of pile mass is sufficient, and rest of the pile reduction will take place with fibrosis. We'll see in another video. The main part I will show you. Before doing the laser hemorrhoidoplasty, we first give 60 joule of energy at the base of the hemorrhoid pile mass without touching the hemorrhoid complex. You can see the light of the laser. can see the changes also there, and then introduce laterally towards the hemorrhoid and going towards the base of the hemorrhoid pile mass and giving energy to the piles. Total energy is given 150 to 200 joule of energy per hemorrhoid, depending on the size and stage of the hemorrhoid pile mass. Initially, third grade and fourth grade hemorrhoid needs 300 to 350 joule of energy, and grade 1 to grade 2 hemorrhoid pile mass needs 100 to 200 joule of energy. This is my ringtone sound. That is not the laser sound. Again, next patient, 56 years old, having grade 3 hemorrhoid pile mass and bleeding. Patient treated with laser abdominoplasty. We are going to laser hemorrhoidoplasty. We are just ablating the feeding vessels here.
Hello.
Hello. Hello. This is 7 o'clock pile mass. We are doing hemorrhoidoplasty for the 7 o'clock pile mass, and then at a time we can do for all hemorrhoids at 11 o'clock and 3 o'clock also. Hardly there is no need to take any stitch or to do any mucopexy. The procedure takes 3 to 5 minutes. Again, this is for grade 3 pile mass. Procedure is same, so that I'm taking another video. So before going towards fissure, it's a horrible routine morning of guy with fissure. You can see the expression of the fissure patient. So fissure means there is a term fissura, which means cleft, suck, or groove, or normal otherwise. The synonyms are anal ulcer, anal fissure, ulcer in ano, chronic ulcer, fecal ulcer, or as per Ayurveda, it is called as perikartika. So etiology, primary cause is constipation, spasm of the internal sphincter, or secondary causes are ulcerative colitis, Crohn's disease, syphilis, or the tuberculosis. Classification is primary. It is in the idiopathic type of fissure. There is no pre-existing disease or any other cause except constipation. And secondary, anal after post-operative hemorrhoidectomy or duodenal fistula treatment, which causes fissure. Another condition that is proctocolitis or the Crohn's disease. So clinical features: pain on defecation, sharp cutting and tearing, and remains up to 2 to 3 hours. Bleeding, slight swelling, large sentinel tag, discharge, pruritus of clothes, pruritus and soiling of the underclothes, and urinary symptoms in some patients also. Management of the fissure in ano: avoidance of the constipation, anesthetic ointment, anal dilator, long-acting local anesthetic, analgesia, muscle relaxant, application of the glycerin trinitrate and botulinum neurotoxin. Botulinum neurotoxin is the Botox injection which is given into the internal sphincter to relieve the spasm or the sphincterolysis. And one hyperbaric oxygen is also used. Surgical treatment includes manual anal dilation, though it is banned now due to the higher chances of the incontinence. It is previously done. So surgical treatment for the fissure is gold standard, that is the internal sphincterotomy. This is the surgical division of the lower third of the internal sphincter muscle, dividing the sphincter at 3 or 9 o'clock position. And the surgical procedure is a choice for the chronic anal fissure associated with the sphincter spasm. It is a quick, simple, and provides immediate relief to the patients. So this is the machine which we have, that is 1417 laser, and the setting is here 8 watt continuous mode and this 100% setting. So we'll see laser sphincterotomy with laser abdominoplasty. Here we are infiltrating locks with adrenaline to separate the mucosa from the internal sphincter. Now 2% halogen, and now we are going to do laser sphincterotomy. Why we have infiltrated here locks 2% plane? Because to elevate the mucosa so that now I am doing laser sphincterotomy. Hardly it takes 2 to 3 minutes, and it is very invasive procedure, laser sphincterotomy. Hemorrhoids. And along with we'll take a hemorrhoid file mass at 11 o'clock. Coagulate the feeding vessel. Basic theory is same for hemorrhoid, up to 50 joule of energy. Then we'll go to the mucosa, and you can see the hemorrhoid pile mass, small hemorrhoid pile mass there. Now we are giving energy into the hemorrhoidal complex up to the base of the hemorrhoid pile mass. Here 100 to 150 joule of energy is sufficient. Hemorrhoidoplasty with laser. You can see the light of the laser. In the same setting with fissure and files we can do. See, inside. So after each application we use ice there. You can see there is complete shrinkage of file mass. When is this for 7 o'clock file mass? Again at mucocutaneous junction up to the base of the hemorrhoid file mass. Minimum 100 to 200 joule of energy is emitted. For one hemorrhoid, minimum 100 to 200 joule of energy is required. So there is complete shrinkage of the hemorrhoid. This is 3 o'clock file mass. Again the procedure is same. After procedure, not a single drop of bleed here. This is a bloodless and minimum invasive procedure. So we have completed all 3 hemorrhoids in one setting. We have completed the procedure. Now we will insert some ice to prevent hematoma. Ice is kept inside. We have finished the procedure. So again, this is another unity case of laser sphincterotomy. Procedure is same. Identify the internal sphincter. Inflate 2 ml, 1.5 to 2 ml of xylocaine with adrenaline at 5 o'clock to separate the submucosal area from the internal sphincter, and then do the procedure like same manner. Procedure is same. So we'll take another video. So the benefits of laser hemorrhoidoplasty and laser for the sphincterotomy is faster recovery, ability to normal return work is very less, and perioperative pain seems to be very decreased, and some hematomas or edemas are there, but it is very low. Perioperative or the postoperative bleeding is very minimum. No urinary retention, or the significantly there is a postoperative low dose of analgesia is needed, and normal return to the work is very fast due to the laser hemorrhoidoplasty. We are doing laser hemorrhoidoplasty in local anesthesia, saddle anesthesia, as well as short general anesthesia. So these are some pictures of pre-op and post-op treatment. This is grade 4 piles treated with laser without any suture before and after treatment. This is grade 4 thrombose piles with fistula in ano treated with laser. We can do laser hemorrhoidoplasty, means laser fistula treatment, laser piles treatment, fissure treatment at the same time with the laser. So we have done laser thrombose piles fistula in the same patient. So this is again pre-op and post-op pictures. So the next topic is fistula in ano. Fistula is abnormal collection between the two epithelial surfaces, and the term fistula is derived from the Latin meaning that is pipe or the fluid. Anal fistula is the tract usually communicates an infected glands and secondary opening to the perianal skin, and which is lined by the granulation tissue. Clinical features are skin, swelling, bleeding, pus discharge, or from the skin opening or skin excoriation or the external opening. So investigations are physical examination, probing, that is digital rectal examination, that is DRE is done, proctoscopy is done, and to rule out the other pathology also, like Crohn's disease and all. And MRI for high anal fistula is done. Recently, MRI fistulogram is the best choice of investigation for fistula. So this is Goodsall rule. This is very important. Draw a imaginary line perpendicular to the anal canal, and it divides anal canal into anterior and posterior portion. The upper part is anterior and below part is posterior. And any external opening to the anal canal anteriorly, it opens directly straight into the anal canal. If it is below 3 centimeter towards anus, if it is more than 3 centimeters, then it takes a curve and opens at 6 o'clock, and any posterior opening at posterior side will directly take a curve and opens at the 6 o'clock. This is very important while treating the fistula by any method, by Shar Sutra, by fistulectomy or laser, or by any method. So the etiology, the non-specific cause is non-cryptoglandular infection, and specific causes are Crohn's disease, tuberculosis, lymphogranuloma venereum, actinomycosis, rectal duplication, foreign body, or the malignancy. So cause of the fistula should be known. Every sample of the fistula should be sent for histopathology to rule out the secondary causes. So types, there are low anal fistula below the anal canal and high anal fistula above the anal canal. It is simple anal fistula with extension or without extension. It is a single external opening, that is multiple opening also, which called as Shataponak Bhagandara as per Ayurveda. Sushrutacharya told the management of the Shataponak Bhagandara also. And multiple other water can fistula is the cause or is seen in tuberculosis, ulcerative colitis, Crohn's disease, or hidradenitis suppurativa or actinomycosis. So the classification according to the St. John's University Hospital is grade 1, grade 2, grade 3, grade 4, and grade 5. Simple, complicated fistula, that is intersphincteric with abscess or 2-year duration tract. Grade 3 simple or transsphincteric fistula, complicated transsphincteric fistula with abscess, and supra and extra sphincter fistula. These are the classification. It is again Park classification. It depends on the superficial fistula, intersphincteric fistula, transsphincteric fistula, suprasphincteric, and extrasphincteric. All detailed classification should be known to each and every surgeon before treating fistula by any method, so that you cannot miss the track. The management of the fistula is, the goal of the therapy is to drain the local infection, to irrigate the fistulous tract, avoid the recurrence, and preserving the native sphincter of the function. And the surgical management is fistulotomy, fistulectomy, sit-on management, advanced flaps and glues, lip procedure, and filler. So this is simple fistulotomy procedure. Insert a probe from the external opening up to the internal opening, best for the low anal fistula. As Sushrutacharya in our text has told, Chedana is the best management of treatment for fistula. So this is nothing but the Chedana karma, that is fistulotomy. Again, this is a lift for the fistula in ano, lift procedure, that is ligation of the intersphincteric fistula tract procedure. This procedure should be done by experienced surgeon or those who are practiced of doing 100 to 150 cases, which can be successfully treated with the lift procedure by that kind of procedures. So it is based on the secure to closure the internal opening of the removal of infected cryptoglandular infection through the intersphincteric approach. And the essential steps are, we have to take incision at the intersphincteric groove. I will show in the diagram so that you will be better know to the procedure. This is the external opening and this is the internal opening. The intersphincteric space is divided here with taking incision, and the intersphincteric tract is excised by ligating towards the internal opening, and this defect is closed with the suture. And simply the process is ligation of the intersphincteric tract, and this will prevent the recurrence of the further infection. So there is good results in lift procedure also. So the new innovative procedure which we are using in fistula is FILAC, that is fistula laser treatment. So what is the fistula laser treatment? There is a localization fistula tract, that is internal opening and external opening. This is the internal opening and this is external opening, and we curate the whole tract up to the internal opening, then insert a laser probe. Here we are using radial fiber, and in hemorrhoids we use bare fiber or the conical fiber. And here this radial fiber emits energy in 360-degree angle, while in bare fiber it emits energy straight to the tip. So this is the laser fiber. Internal opening is here, and we are coming outside by pulling the laser fiber outside like this, and the whole tract is ablated with laser, and here internal opening is closed with the suture. So energy radially emitted into the fistula. Principle of the treatment is it is taken at 30 to 15 watts, 8 second per centimeter, and first 3 seconds the fiber is in the situ, and closure of the internal opening is done with the help of suture. So the laser fiber here emits energy in 360-degree angle. So the epithelialized tissue destroyed in controlled homogeneous way in 360-degree angle, and the photothermal effect makes fistula tract to completely collapse. So it is completely collapsed with the laser. The end of the operation and post-operative day, the endosonological results, we will see the complete occlusion of the tract. So another method is there to close the internal opening by mucosal flap by taking a mucosa over the internal opening. So advantage of the fistula laser treatment is there is a high success rate, low recurrence, quick treatment, minimum invasive, minimum blood loss, minimum pain, less trauma, instant relief, and quick recovery. And healing rate is up to the 80%. Only minor irreversible impairment of the continence, but less chances of incontinence is there. And it is very good in females, specifically in anterior fistula, to save the sphincter, to save the incontinence in females. So laser is like a delicate procedure, and it is specifically good for delicate women. Some disadvantages of the PHYLAC are blind procedure and fail to diagnose the infected crypt, may miss the secondary tract also. So I always advise MRI fistulogram for the patient to find out the any missing tract there. And learning curve and cost of the device and fiber is very high. One fiber is costing 22,000 rupees. So we'll see the PHYLAC procedure, that is fistula laser treatment. Hi, Dr. Praveen Sahave from Abhyuday Piles Laser Hospital, Rameshwari Square, Nagpur. Today we are going to do a PHYLAC procedure, that is fistula laser ablation treatment for recurrent fistula in ano. The patient was operated 2 to 3 times outside than our hospital, and today the patient visited to our hospital and we have planned this procedure. It's a daycare procedure, and we can do this procedure in local anesthesia also. There is no need to stay for long duration in hospital, and no post-operative discomfort to the patient. Patient external opening is found at 4 o'clock and internal opening is at 6 o'clock. A thorough wash is given and thorough tract is curated, and internal opening is identified. A radial fiber probe is inserted from external opening up to the internal opening, and the laser energy is given. The internal opening is closed with Vicryl 20 round body needle, and patency test is done with the hydrogen peroxide or methylene blue, whether the internal opening is completely closed or not. So this is very daycare procedure, easy to perform. Chances of recurrence and incontinence is very less. And in this today's COVID pandemic, this is best procedure I can say for fistula. Mostly the women who is having anterior fistula, there may be a chances of incontinence in conventional method, but in PHYLAC there is no chances of incontinence, and this method can be done in local anesthesia also. So we have given the energy up to 500 to 600 joule of energy. The external opening is widened for drainage purpose, and internal opening is closed with Vicryl suture. And we have, so again we combine fistula laser treatment with slot. Slot means submucous ligation of the fistula tract. This technology was developed by Dr. Pathak sir from Jabalpur. He is MBBS MS general surgeon, and this is having also good result. So our ultimate aim is to give results to the patient. So we are combining laser with the other methods also. So what we do in slot, we take a incision at the mucosal level up to the just beside the internal opening, and the tract is dissected there, and suture is taken, and rest of the tract is curated thoroughly, cleaned, and laser ablation of the treatment is done. So here we are ligating the tract at mucocutaneous junction just towards the internal opening. Again in the same patient, the laser energy is given from the internal opening towards external opening where we have taken the incision, and this is also a sphincter saving procedure, and this is the radial fiber which we are using, which emits energy at 360-degree angle, and rest of the tract is ablated with laser, and the fistula will easily heal with slot. This is again with fixation device with filac. Fixation device is good for anterior and straight fistula which are situated at anterior side and whose tract is directly communicating with the internal opening. So this is the fistula. Anterior opening is here, external opening is here, and internal opening is at the same side. This is the cutter which we rotate to cut the fistula tract inside the towards the anus, and there is a cap inside the internal opening, and you can see the whole fistula tract is embedded inside the device. I will show you. This is the tract. This is the fistula tract which is embedded there, and then internal opening is closed, and rest of the tract is ablated with laser. This is the internal opening. This is the fistula tract which we have completely removed with the fixation. This is also a minimum invasive procedure we can do in local anesthesia also, and we send this for histopath to rule out the other secondary cause of the fistula. This is again fixation method. This cap. The patient was having history of operated for abscess, and which is converted into corneous gangrene before 1 year back. We have fixed the cap. How the fixation device is fixed? You can see this in the slide. We rotate this cutter to excise the tract of fistula. I have reached up to the internal opening. I will show it to you. Okay, I have reached up to the internal opening. And then rest of the tract is ablated with laser. And the internal opening is closed with Weichel 20. I will remove this cap now and I will show you the tract which is embedded inside. So closing of the internal opening, same which we have seen in laser filac. 20 Vicryl is taken. Probe is there, and we are closing internal opening with 20 Vicryl. This is also simple method. So this is a simple internal closing method for fistula. Then IFTAC with filac. IFTAC is introspection of the fistula tract and Kshar Sutra ligation. This method was invented by Dr. Sahu sir, who was from BHU, and this is the best method for the complex fistula or long fistula or recurrent fistula. What we do, we create a window here at 6 o'clock or 12 o'clock, depending on the side of the fistula, and we intercept or bifurcate the tract of the fistula or the cryptoglandular infection, and the rest of the tract healed by granulation, and the Shar Sutra is applied at the window to internal opening. This is the basic of the ifta. Here you can see the probe. Here window is created for the ifta, and this opening, external opening, is now open in the window, and same tract is here also. It is also opened at this window, and after that a laser treatment is done from the external opening up to the window in both the tract, so that the fistula will heal fast, and in window to internal opening a Kshara Sutra is ligated. So ekam shastram na adhyanam na vidyat shastra nishya tasmat बहुश्रुता विजानियात सब चिकित्सका. सो शास्त्र कोई भी हो, आयुर्वेद रहे या आधुनिक शास्त्र रहे, अल्टीमेटली सबका एम चिकित्सा करना होता है और रोगी का रोग दूर करना होता है. तो जैसे राष्ट्रसंत तुकडोजी महाराज ने कहा था कि अध्यात्म और विज्ञान के सहयोग से हो सब सुखी, तो वैसे ही हमारा उद्देश्य है कि आयुर्वेद और आधुनिक विज्ञान के माध्यम से हम लोगों के रोग दूर कर सके. We can see both tracts here which are opening at, this is anterior fistula, both external opening are 8 to 10 centimeters away from the anus, and we have created a window, and the both tracts are communicating at this window, and we have inserted Shara Sutra there at this probe site, and the rest of the tract were curated and ablated with laser. You can see the ablation of the tract with laser, and here the probe is there where we are going to insert a Shara Sutra, and which is changed after every 8 days. This is posterior fistula, that is horse-shaped fistula or shoe fistula. Here 3 and 9 o'clock external openings, both are communicating at 6 o'clock, and we have created a window, that is iptak, along with the phylac. So iptak is introspection of the fistula tract. You can see, I will pause this video. You can see the Shara Sutra here. We have kept Shara Sutra at posterior. If the fistula is posterior side, we create window at posterior side. If the fistula in previous slide was anterior side, so we create the window at anterior side. And rest of all these tracts are curated, and thorough wash is given, and laser treatment is given. If we do this fistula with conventional way, it will take 1 year to 2 years for healing, and with iftak along with the phylac, it will take hardly 1 month to 2 months to heal. So the duration of the treatment is very less, no post-operative complications, continence is maintained, and the duration of the treatment is also very less. So this is again phylac, simple phylac for the fistula in ano. This is anterior fistula and straightly directly open into the anus. So we'll close the internal opening here with Vicryl. We curate the whole tract and give the laser energy with the laser fiber. This is again very simple. So complete tract is coagulated. So pyloradial sinus. The pyloradial sinus is the element that occurs in the lower third of the back of the region, and it is common in 15 to 13 age group, and rarely the onset after 40 years. And 1% population is affected with this disease. In this disease, a painful wound is formed over the midline, over the 5 to 8 centimeters in the anus, from the anus and at the back of the region, and where pus goes on oozing out. The wound doesn't heal spontaneously because almost there is tuft of hair bunch inside the wound. Pylo means bunch of hairs, nidus means hairs. So there is a bunch of hairs inside the sinus. So etiology of the pyloradial sinus is sedentary occupation 44%, family history 38%, obesity 50%, And local trauma, that is in army recruits, 34%. Male gender is very common, dark haired individual, moisture, deep natal cleft, poor personal hygiene. In females, pyrenoidal sinus can occur at breast site. Pyrenoidal sinus is very rare in females. Uh, so classification of the pyrenoidal sinus according to Tesel is asymptomatic sinus, acute pyrenoidal abscess, chronic restricted in navicular area. That is fourth grade is chronic exudated beyond the navicular area, and fifth is recurrent pyrenoidal sinus. So acute abscess form of pyrenoidal sinus is having pain, swelling, redness, fever, and malodorous fluid. Anaerobes E. coli is 77% and aerobes 4% and mixed are 17%. So the primary goal of the treatment for the pyrenoidal sinus is reliable wound healing. So post discharge should be very less, low risk of the recurrence, a short period of hospitalization, minimum inconvenience to the patient, minimum wound management problems, and resume normal works as early as possible. So the surgical options available for the pyrenoidal sinus are incision drainage, excision of the sinus, leaving the wound open, or some primary closure method, that is Z flap, rhomboid flap, Limburg flap, Bascom flaps, Caridakis flaps. So most of the surgeons are doing this. One of the another method, that is laying open and curettage under local anesthesia, that is called as locula operation. In this method, the pyrenoidal sinus is incised, deroofed, and then excised without removing the sinus with the void margin. So we do a laser pyelonidoplasty. It is very simple. It can be done in local anesthesia. It can be done in OPD basis. Patient walks in and walks out. The setting for is 10 watt to 14 watts for 1470 nanometer machine, and debridement of the tract is done. Scooping of the tract is done with brush, irrigation with normal saline, and first removal of the hairs along with the wounds. If set on kept for drainage, it should be kept for 10 to 12 weeks. Better results are there, as there is good drainage and control of sepsis, and which encourages the epithelialization, fibrosis, and maturation of the tract. So what we do, we passes the radial fiber at internal opening, and 100 to 120 joule of per centimeter energy is given in the pyrenoidal sinus. So those who are interested to see and watch the videos, please subscribe our YouTube channel, Dr. Praveen Sahave, so they can watch these videos in details with explanation also. So this is laser pyelonidoplasty in local anesthesia. We have given local, the sinus is curated, and we are inserting the radial fiber inside the pyelonidal sinus. You can see light of the radial fiber inside the tract. The energy emitted in 360-degree angle and completely epithelize and coagulates the sinus tract. After each application of laser, we should apply ice there for prevention of the thermal damage by any method. Slowly pull the fiber and give the energy. Always wear protective glass while doing laser and surgery. This is again, both the openings are already enlarged, curated, deepitalized, and laser energy ablation done. You can see the laser inside. This is very minimum invasive procedure. Then this cavity is packed with the Necrogel jelly or any antiseptic solution, and patient can do his dressing at his own hand without any assistance, and no need to come to the hospital regularly. So this is simple method of laser pyelonidoplasty. So treatment for pyrenoidal sinus and fistula, conventional versus laser. Laser can be done in local anesthesia It is daycare procedure, low post-operative pain, recovery time is minimum 3 days, recurrence is low, and complications are also low. So these are some pictures of pre-operative and post-operative complication. This patient was having 65 years old, known case of diabetes with hypertension. He was having external 6 opening. Imagine diabetic patient having 6 opening, and the fistula was having near about 5 to 6 years of duration. You can see these threads. These are the silicone threads which we use for drainage purpose earlier, and we did the laser treatment for this patient, and the fistula completely healed within 2 months.
Looks a little bit better. It's currently set to auto. When I click on this
Complete healing of the fistula. So this is again before and after fistula laser treatment. This is pilonidal sinus before and after. Hardly there is minimum scar. So till date at our hospital we did a laser abdominoplasty 3,595 cases, laser sphincterotomy 3,289 cases, laser fistulectomy 1,190 cases, laser pyeloidoplasty 150 cases, sloughed submucous ligation along with the fistula and laser treatment 15 cases, IFTAC with FILAC 240 cases, and fixation with FILAC 30 cases. This is the data of the laser treatment which we have did in our hospital with the blessings of our gurus. So my paper published in Tokyo, Japan, on beam laser, which is used for all grades of hemorrhoids, and our successful 150 more doctors from all over the India for laser training. We are giving laser training to every month to the doctors. जे जे आपणासी ठावे ते सगळ्यांशी सांगावे, या उक्तीप्रमाणे हम लोग ट्रेनिंग देते हैं. जो कुछ ज्ञान हमने प्राप्त किया है उसको समाज माध्यम तक पहुंचाने का काम करते हैं. और वी आर regularly conducting the courses. The eminent personalities, the doctors coming from Madhya Pradesh, Chhattisgarh, Telangana, and Karnataka, Kerala. We are this doctor from Haryana, and they are doing well in this. It's our pleasure that MBBS, MS doctors are also coming for the training, and I think the issue of nopathy is here. Only ultimate goal is to give the complete recovery to the patient. Again, the doctors coming from all over the India. So this is our guru, Dr. She. Dr. She has shown me the path of laser in my life, and thank you very much. Take care, and all is well. Thank you very much.
Thank you very much, sir, for such a wonderful session with all the details, right from physics, all the details of surgery. Each and every aspect was covered with videos, graphics, animations. It was really one of the best experience regarding the management with all such practical aspects. Thank you very much. Now, I hope all the participants must have benefited with this enlightening session. I would like to request the lecturer from Shalya tantra department, Dr. Neeraj Gechode sir, to please introduce and invite our respected moderator of this session. Over to you, Dr. Neeraj Gechode sir.
Thank you, Dr. Hadole sir. Welcome everyone. This is Dr. Neeraj Gechode, Assistant Professor of Shalya tantra at Jupiter Ayurved Medical College and Hospital, Nagpur. Is I audible? Hello?
Yes, sir. Please go ahead.
Okay. So, thank you so much, respected Dr. Praveen Sahave sir, for the excellent, clear and clinically oriented presentation. I would feel pleasure to introduce our first moderator, who is none other than respected Dr. Subhash Raut sir. Dr. Subhash Raut sir is the Dean and Head of the Department of Shalya tantra at Government Ayurved Medical College, Nagpur. He has several national and international publications. He trained various postgraduates with his immense knowledge. Amongst few are connected with us in this webinar. It's an absolute coincidence that our first speaker, respected Dr. Praveen Sahave sir, is also remained a brilliant student of him. I may request respected Dr. Subhash Raut sir to moderate this session and put your expert comments. Thank you, sir. Dr. Subhash Raut sir.
I request respected Subhash Raut sir.
Am I audible? Am I audible?
Yes, sir.
Here.
Yes, sir.
Hello. Hello. Can you hear me? Yeah. I am very much thankful to Dr. Subhash Wage, who has requested me to moderate duration. But because I was having certain my official engagements, I could not join the session within time. I joined very late. By the time I joined the session, Dr. Sahave had started his lecture, and very few slides I could have witnessed for today's session. The principles of management of fistula in ano and conditions like to the fistula, that is nadivran or sinuses, is the radical excision of the entire tract. Whatever the method you adopt to remove the tract or to treat the patient should always aim for the radical excision itself only. In Sushruta Samhita, several modalities has been described for the management of this disease. And the principles, those are led by Sushrut, are also being adopted, and the various modalities has been developed by any other medical sciences also. On the ground, on the basis of these principles, the management of fistula was described by Dr. Praveen Sahave, and he has well elaborated the procedures those he himself performed, and the patients were benefited from these procedures. I think this entire session was very much fruitful to get the brief of the fistula in ano with various techniques and technologies. Because application of technology is much more important for the management of or for management of any of the disease. Not only in case of the fistula in ano, but in every walk of management, we can use the technology, and application of technology is always benefited to the patient. So I congratulate Dr. Praveen Sahave for his elaborative and fruitful lecture. Hello.
Thank you, sir. Thank you very much. All today I am here in front of you is the only blessings, the guru, the guide like you. And today, whatever I am here is only due to you, sir. Thank you. Thank you very much.
Thank you very much, respected Dr. Subhash Raut sir, for accepting our request for being a part of this national webinar as a moderator. Thanks a lot. I would also like to request all the participants that they can join the various training programs conducted by respected Sahave sir related to various surgeries. they can surely contact personally Save sir for various training programs. Now moving towards further session, I would like to request Dr. Avinash Bharti sir, who is working as assistant professor in Department of Shalya Tantra, to introduce and invite our second guest speaker. Over to you, Dr. Avinash Bharti sir.
Thank you, Hadole sir. Thank you very much. Hello everyone. I am feeling very grateful to introduce you to Dr. Pramay Dhage sir on this great platform of knowledge. He is now well-known consultant surgeon and laparoscopic surgeon in Nagpur. He did undergraduation from Government Ayurved College, Nagpur, and post-graduation from PDEA College of Ayurved and Research Center, Pune, Akhurdi. He also done fellowship in minimal assistive surgeries with a diploma in minimal assistive surgery. He is the life member of World Association of Laparoscopic Surgeon. Also, he is the life member of ISCP. He is the director of Dr. Dhage's Surgicare Clinic. Also, the director of Yash Hospital and Research Center, Nagpur. It is the 100-bedded multi-specialty hospital to open in couple of days. He is the course director of laparoscopic training course for surgeon and gynecologist practicing in Nagpur since last 6.5 years, performing all open laparoscopic surgeries in Nagpur and its peripheral districts, especially most of small and large bowel surgeries, including resection, anastomosis, perforations, pancreatic pseudocyst, duodenal perforation, hysterectomy, inguinal hernia, ventral rectopexy, liver-related cyst, and many more. Thank you, sir, to be here with us to share your valuable knowledge. I would like to request you, sir, to start the session. Thank you, sir.
Hello, everyone. Today I am here just to let you know that we all being a BMS graduates, still we are trying to do better surgeries. We are trying to adopt the innovations which have been placed in the medical fraternities right now. So just, it's my small trial, I must say, a small contribution in the field of laparoscopy, especially for the colleagues of my fraternity, so that they can also have some lessons from this and we can have a better future for our graduates also. Now I have been given the topic of surgical laparoscopic intervention in surgical disorders. So first we will try to know what are the surgical disorders. That is, whenever there is a breach in the integrity of a body tissue and we need to get free from that, we need to go for a surgery. So what are the breach in integrity indicate? It can be an abnormal growth, it can be an inflammation, it can be a division of two tissues, anything we can say. So there are some surgical disorders which I am showing over here. Those are con, appendicitis, cholecystitis, which might be calculus or acalculus, perforations, inguinal hernias, ventral hernias, ovarian cysts, renal calculus, and many more. So as per my topic, what is the new era of surgery? The newest era of surgery is minimal access surgery. Now, what is minimal access? There are two forms, we must say, minimal access and minimal invasive. Minimal access is that in which you have a small access with a keyholes, you try to do the surgery. And in minimal invasive, you try to lesser invasion, you try to avoid the invasion or damage to your body tissues. So right now we are speaking about the minimal access surgery, so that we can have a smaller surgical incisions and smaller scars, and we can maintain a beauty. So what are the types of minimal access surgery? There are 4 types specifically, which are running throughout the world right now. One is single incision laparoscopic surgery, in which there is a single but a bigger port through multiple instruments can go into enter our body and we can operate. Other is hand assisted laparoscopic surgery. This is specifically used when we have to operate on bigger masses in our body. The another is POEM. POEM is per oral endoscopic myotomy, which is done usually from achalasia cardia. Another is nodes. nodes is the most advancing nowadays. There are many researches going on worldwide, so that because this sort of surgery is using the natural orifices, transluminal endoscopic surgery. This will help to lessen the scarring of our body to much further extent. So just we will have a small introduction to the laparoscopy system. You can see that the basics of the system is one is screen, because when we are operating in open surgeries, we directly see the tissue. But in laparoscopic surgery, we have the virtual imaging. And for that, first and basic requirement is screen. The another is camera console. Camera console is the device which processes the image. The camera head is the device which receives the image. Scope, that is the telescope which will enter into the patient's body and help us to gain the image and then process the image. The another thing is light source. In our abdominal cavity, we know that everything is, there is no light, natural light inside, because we are operating in a closed compartment. So we need a light source for that. So again, light source, there are many. It might be halogen light source, it might be xenon light source, or it might be LED light source. The next, insufflator, the most important thing. The insufflator is the device which helps us to introduce gas into the peritoneal cavity and create space for operatives. Because for operating on any of the body part or any of the organ within the abdominal cavity, we need to create a space. If we are touching here, there, we can't operate. That's why to create that space, we need to introduce gas, and that is specifically carbon dioxide, because it has lesser side effects on the body. And at the end, as we know, as in open surgery also, we know we require energy sources. So energy source is the final requirement for a laparoscopic surgery. Now, what are the laparoscopic surgeries which are very common in our day-to-day surgical and gynecological field? In general surgery, we come across appendicectomies, cholecystectomy, duodenal perforation, inguinal hernias that might be direct or indirect, ventral hernias, and diagnostic laparoscopies. In gynecology, we go for hysterectomy, we go for ovarian torsion, we undercome dermoid ovarian cyst. There are chalk-less ovarian cysts, or that might be called as endometriomas, or we need to go for myomectomy. These are the routine procedures which we come across. Right now, I would like to share with you all few surgical videos of my surgeries, just to have an idea that we are how minimally invasive, in a minimal invasive way we can operate on the patients, and that help us. And the second thought is that laparoscopy is the technological innovation, so that it's a very easy thing that we should adopt to all these things, because in the future of surgery is going to be minimal access, and for that we need to train ourselves. So this is laparoscopic appendicectomy, which video I am showing. Now you can see that I am getting the access to the abdominal cavity with my port. Now this, I am into the abdominal cavity. You can see a very good image inside. My one of the instrument, which is called as Maryland, coming in. This is my Alice forceps, which is Babcock forceps, which is coming. You can see the uterine artery. Now I am searching for, sorry, that was external iliac artery. Now here I am searching for appendix. To search for that, firstly we know the basic that we have to go to the cecum and search for the tinea coli.
Sorry, sir, may I intervene? Video is not visible.
I think, sir, to how many people it's not visible? Is it
No, sir,
all?
it's not visible. Please minimize this presentation first.
Okay, just a second. Yeah. Yeah, can you see now?
No, sir. Just close the presentation. Okay,
Yes.
just minimize now. Start your screen sharing.
Yeah, just a second.
Okay, it's visible,
Is it visible now? Yeah.
Yes, sir, it's
Please
visible
start
now.
again.
Sure. Just I will just go back. This is how I'm entering the peritoneal cavity. You can see the bowel loops. Now one of the instrument, which is Maryland, is entering. This is my Babcock. You can see the iliac artery, the pulsations, which are very strong. Now the basics, as we know that to find the appendix, we go to search the cecum. And for the base of appendix, we need to see the cognizance of all three tinea coli. So I'm searching the appendix over here. We will shortly have it with us. Yeah, this is the appendix. With my Babcock forceps, I'm holding the appendix, and now my energy source, which I have told you that which is very important for the surgery, will come into picture now. Just I'm trying to locate the base of appendix. I'm just trying to define till where I have to dissect. Yeah, this is my Vesicilla instrument, which has come into picture now. You can see it is coagulating the tissue. And at the end, you will find that we have not even seen a single drop of blood. Because as I'm saying that this is a minimal access surgery and I'm using a good electrosurgical equipment, we can easily make that there won't be any bleeding at the end. Yeah, here I am at the base of the appendix. You can easily make out the base of the appendix. I'm trying to coagulate the appendicular artery there. Just small bursts of currents which are adequate there so that the vessel or the vascular part has been coagulated nicely. Now here's done. You can see the base of appendix very nicely. Now the second step is to ligate. Now here you can see I have brought within the picture a small cut Vicryl 20 thread. I preferably don't use loops for this. There are many options for ligating the base of appendix. Here I'm using the Vicryl and I'm going to do an endo knotting here. You can see that I will be going to put a square knot and then multiple throws to ligate the base of appendix. I'm just forwarding the video a little bit because it will take a lot of time. With laparoscopy, I have seen that we can complete an lap appendicectomy case within a period of 15 to 20 minutes hardly. And while performing an open appendicectomy, many of the times we need to, when we try to gain access to the appendix, we have to go through many layers of our skin and muscles, fascia, and it consumes more time than laparoscopic appendicectomy. Yes, you can see how I'm tightening the knot at the base of the appendix. Then again, multiple throws over that knot so that it is tightened very nicely. We have completely dissected the appendix from his mesoappendix, but still we don't see a single drop of blood dropped anywhere. Now I've cut the excess of Vicryl and the Vicryl is going out of my picture. Again, my energy source has come into the vision. You can see that I am coagulating the base. Here in open surgery, we use the surgical blade to cut the appendix or to perform the appendectomy. But here you can see I'm using energy sources. I have seen it beneficial in many terms because when I'm using an energy source, the base of appendix, which I'm trying to cut it off, it gets coagulated. The proteins are coagulated, so there are least chances of leaking. Second, whatever the contents of the lumen of appendix is there, it don't easily get dropped down from it. So the contamination of the cavity is also reduced. Now here you can see the appendicectomy is completely performed and you can see the lumen of the appendix is nicely obliterated. Now the specimen is kept aside. Here I prefer to change my screw from 10 mm to 5 mm so that I can remove the specimen without additional incision on the skin of the patient. Here the appendix has been pulled out of the body. The specimen is being retrieved and it's gone out now. Now again, I'm introducing my 10 mm scope. I'm coming into the abdominal cavity. You can see everything is done nicely. There is not a single drop of blood. You can see the stump of the appendix. It's very nice and clear. Now I am going to perform a bowel walk. This is preferably done to C4. mucus diverticulum. Thank you. Now another case. Just a second. Now the second video I would like to show you is of gallbladder calculus. Again, we know for the conventional method, when we are performing a cholecystectomy, we have to take a huge incision that is absolutely covering the complete right subcostal region of the patient. But with the help of this minimal invasion, with the help of laparoscopy, we can just do this surgery with only 4 pinholes. In the slide, you can see very nicely the location of the 4 pinholes with which we are trying to operate. All of these videos of mine are on the YouTube. I have a channel which is named by my name, Dr. Pramay Dage, where you can have a good access from there also. Here you can see the gallbladder which has been lifted by me with another instrument, holding it at its fundus. Another my Babcock is holding the Hartmann's pouch, and the hook, which is a very beautiful instrument for dissection, is being used by me to dissect the gallbladder. Especially right now, I am trying to dissect the Carot's triangle. The Carot's triangle is formed by a cystic artery, cystic duct, and the base. And here you can see just I am trying to dissect only and only the peritoneum. One thing a surgeon should remember is that when we are performing any abdominal surgeries, the surgeon should only and only dissect the peritoneum, visceral peritoneum. Because if you are going through the visceral peritoneum, you are on the safer zone so that you won't damage any of the vital structure, and you can easily identify if something comes in the midway of you. Now you can see that with medial and lateral traction, my hook is trying to lift the visceral peritoneal tissue and dissecting it apart. Here, slow and steadily with small bits, I will proceed till I will dissect the cystic artery and cystic duct completely. This is the lateral dissection. Fast forwarding the video, you can see that I'm trying to do the lateral dissection to create a window behind the cystic artery and cystic duct so that I can easily clip them. Yes, small bits of tissue are being cut by me. Now you can just make out a small tubular structure behind my hook, this where I'm pointing my arrow. That is the fibrofatty tissue. Now you can just see a small indentation and a small bubble-like structure just below my hook. This portion is the cystic lymph node. Now my hook is trying to dissect over there. You can see that I have lifted something. I'm pointing it out and coagulating it. That is the cystic artery. I'm trying, as the cystic artery is very small, I'm daring it to coagulate it with the hook. And you can see the cystic node. The cystic lymph node is the landmark which indicate that you should not go below the cystic node, or else you are in a higher chances of damaging the common hepatic duct. So I have just coagulated the cystic artery above the cystic lymph node, and now I'm trying to release all the fibrofatty tissue around the cystic artery so that I can easily clip it off. You can just see with this minimal access procedure, which we are doing with the help of laparoscopy, there is very minimal blood loss, very minimal tissue damage, and very minimal scars and incisions on the patient's body. I'm again fast forwarding this. Now I will show you the cystic artery and the posterior plate, which will be very nicely dissected by me. The 1/3 of the cystic plate should be nicely dissected. Yes. Now you can see from here that I have created a window here. My hook is there in the window, that I have created a nice window and I am just trying to go through and through behind the cystic duct. Yes, this is the cystic duct which I am pulling. I'm just trying to release off the excess of fibrofatty tissue so that my Liga clip will fit on it very nicely. Yeah, the window is nicely evident now. This is the lateral dissection of visceral peritoneum. You can just see that I am not piercing the gallbladder. I am not neither piercing the liver tissue. I am just going in contact with the visceral peritoneum and there is no bleed. The posterior window and trying to dissect the cystic duct very nicely. Now here comes the Liga clips. These are the titanium Liga clips. These are very secure and you can see that I'm ligating the cystic duct with this. 2 on the patient side and 1 on the specimen side. And then my scissor will come into picture and I will, yeah, this is my third Liga clip. Ideally, for cystic artery also we use Liga clips. If the cystic artery is of that caliber, if the cystic artery is very small, we can dare to cut it off or we can dare to coagulate it. Yeah, see here the cystic duct. Cystic duct is falling laterally here. This indicates that you are on the right path, because if the duct which you have cut is falling medially, that will indicate that you have cut the cystic, you have not cut the cystic duct, but you have cut the common hepatic duct. Yeah, now you can see that very nicely my hook is dissecting my gallbladder from its posterior attachment. The loose areolar tissue behind the gallbladder is helping me to get a good plane with no bleed. Now the gallbladder will be dissected off very nicely. Yeah, a little bit of liver parenchymal injury, but it is nothing to worry. That bleed stop of its own. There is nothing to worry for such small bleeds. And the thing, another is that with the laparoscopy, the images which we see are nearly 10 times magnified. So if we, when we see a tiny drop, it's very less bleed actually. You can see the final fragment of the gallbladder is being dissected. Yes, the gallbladder is dissected off completely now. Now I have brought in picture a small workspace so as to mop the minimal amount of bleed that has occurred over there. For such a small bleed, we don't prefer to go give a saline lavage. A simple workspace cleaning is sufficient. The fossa is dry, there is no bleed, cystic duct is falling laterally, means you are safe and everything is going fine. Now the time is to retrieve the specimen. You have to, you can see the specimen is coming out from here. That is from the xiphisternum port and the specimen will be out. So with the help of laparoscopy, you can see a huge incision has been avoided for gallbladder excision. Now another video of my surgery, which is of for ovarian torsion with acute appendicitis. Basically, here I am not discussing the etiology of the disease and other things, because I am just here to show what better surgical things we can do with the help of laparoscopy. Now, this case is of a just young female of 18 years. Now, you can have a thought that if a female of 18 years having severe abdominal pain, nausea, vomiting, having an ovarian torsion, having acute appendicitis, if we need to operate that patient with the conventional method, then the patient will have a huge scar, and that just at the age of 18 years. So I am here doing a laparoscopic surgery for the patient. I have seen the left tori, that is okay. Yeah, in the right side, we can see a black mass. That the mass is coming out now. Initially, it was thought to be an ovarian torsion, but when I went inside and brought the lifted the black mass, I can see a white ovary behind. This means this is a very rare case of tubal torsion. It might be a paratubal cyst, paraovarian cyst, which has undergone torsion, and only the tubes have been necrosed. The ovary is still good. So I have taken a decision to excise it, only the necrosed part of the tissue. You can see that I am removing and rotating anti-clockwise so that the torsion of the cyst is relieved. Here I'm lifting the tissue. Now I'm just having a view from where should I excise so that ovary may remain viable and the necrosed tissue comes out of the body. Now my energy source, that's a vesicular, is coming into picture. I am very fond of using such device because it has a very good impact on the tissue. It causes very less bleed. It has a very good and controlled emission of energy on the tissues, preventing the lateral damage. Now you can see I'm just coagulating the tissue to the extent that complete water has been evaporated from the tissue. That will ensure that there won't be any bleed post-surgery. Very shortly, we will have the specimen out. Yes, only a small fragment of the specimen has been attached now. I will be sizing. You can see here. Now the cornea. Here you can see I'm trying to coagulate the cornea also because I want no any other further complication at the cornea site, which is a common site of complication in patients. That's why cornea has been coagulated up to the uterus. Now you can see there is no bleed. Absolute, the region is dry. As the CT was for this patient was stating that patient is also having appendicitis, we have decided to go for appendicectomy also in the same sitting without change of any incisions. While performing open surgery, when we change the site of our operation or our interest, we have to make some changes in the incision, or either we had to increase the length of an incision, which will create a bigger scars and further more complications. As if we also know that due to open surgical scars, many of the times the patient in future has abdominal issues due to bowel gets adhered due to the scar sites. In laparoscopic, it has been noted that there is very less adhesion of the tissues and very less post-op complication in future life also. Now you can see that I am dissecting the mesoappendix of the appendix. Very shortly we will reach the base. I am fast forwarding this video. Here again my vehicle comes into picture because I am fond of like putting the knot intracorporeally. So I use a vehicle to fragment, put it into the cavity, and then ligate the base. In the initial phase, we face some difficulty while trying to ligate. Now here you can see my sealer instrument has come into picture to coagulate and dissect the appendix and perform appendectomy. Now I have both the specimens with me. For the removal of such a big specimen, I can't increase the size of my incision, because if I am doing so, then there is no use of laparoscopy in the field. So you can see I have used a endo bag. Now this endo bag has been created from a simple hand gloves which we use for the surgery, a routine glove. Now what the specimen I am putting into the endo bag, which has been made by me at the moment of during the surgery with the help of simple glove. My specimen is within the endo bag. Now I am going to pull the endo bag and making small fragments with the same incision. I will be removing the specimen. Here you can see that I am giving thorough lavage to the peritoneal cavity because the contents of the ovarian cyst which we have removed, that has caused few contaminations, and the inflammatory fluid which was there due to the necrosis, that has been removed. Now another surgical video that I would like to show, which will help us to know how the minimal access surgery is beneficial, is of duodenal perforation. This is a very young chap, just a 17-year-old male child. He was on addiction of NSAIDs. So one day he had severe abdominal pain, distension, absolute constipation, hypotension, tachycardia. He came to me With a smaller abdominal size, I was in a doubt how could I perform it laparoscopically. It was a challenge for me. But considering the post-surgical complications of laparotomy, I have taken a decision that I should go and try for laparoscopy. Now here you can see that I have entered the peritoneal cavity and there is a very bad vision inside. You can see just the greenish fluid and pus flakes all around. With the help of the insufflator, as the COT is entering the peritoneal cavity of the patient, you can see that we are getting a little bit of better vision. Now I have put inside my suction. I have collected some of the fluid for pus culture and sensitivity, some for F-distan, and the remaining fluid has been sucked off with the help of a suction. Now you can see that suction is sucking off all the bilious fluid that is seen in the peritoneal cavity. Again, another thing which you can see very nicely is that the edematous appearance of all bowel loops, the edematous appearance of the peritoneum. See the pelvis of the patient, how much contaminated it is right now. And for such surgeries, we need to completely open the abdomen. But right now, this is what I am trying to do is through laparoscopy, that is through minimal access. I'm trying to do a better surgery so that it will help the patient to land up in least complication in his future life. You can see I'm removing all of the contamination. I'm trying to visualize the appendix also at the moment. Yeah, there it is there and it is good. The first challenge is to identify the perforation site. We need to first identify from where this contamination has occurred. Here I'm trying to visualize the appendix. The appendix seems to be healthy. This is the appendix. In such an inflamed tissues, it is very difficult to identify the different structures. So we need to be very precise about the locations and the pattern, how to identify. As if I have stated in my appendicectomy video, that with the help of Tinea coli, we can identify the appendix. Now here you can just see a very dark green fluid is coming somewhere below the liver. You can see the gallbladder here. This is the gallbladder. Just below that, you can see two small perforations located on the duodenum. So this is the duodenal perforation, which has created all this mess up in the abdominal cavity of that child. Now, after being locating the perforation, I am now relieved because I know for where I have to do the surgery. I'm just trying to clean up the contamination, because once this all contaminated things have been removed from the peritoneal cavity with the help of copious lavage of NS, I will have a very good vision. You will also appreciate the change in vision once everything is clean. You can see how the pus flakes have been covering the liver and how I'm trying to move it off. This is the liver, what you can see right now. Yeah, I'm below the liver now. This is the gallbladder where I'm touching. Yes. After having copious lavage, now you can see how the vision is better now. And you can easily visualize the bile coming out. The bile indicates that it's a duodenal perforation. Yeah, it's a very nice dark greenish bile coming out. And there are two perforation sites at single instant as a difference of 1.5 centimeter from each. So now the challenge is to suture this perforation because I am doing it laparoscopically. So I have taken a 2O vicryl round body needle through the skin itself, because the round body needle I have to take here. In the previous videos, you have seen that I am just knotting, but here I have to do the suturing. So I have to bring in picture the needle, which I have been put it now. Now you can see that I am doing an intracorporeal suturing. This is called as intracorporeal suturing. The suturing into the peritoneal cavity with the help of a needle. The tissue is very friable. So here we need to be very careful that we do not cut through. The reason is the edema. The edema due to the heavy bilious contamination of the peritoneal cavity has led to the edema of the bowel and had made it very fragile. So I have to be very careful while doing this. You have seen that I have gone through the edges of the perforation and now I'm tying the knot. It takes a bit of experience to do these things because right now I'm not suturing a very inflamed tissue. Secondly, I'm suturing just below the liver. I should not cause any injury to the liver with the needle also. Second thing is, you can see that I have pulled my previous knot. This helps me to bring the perforation nicely under vision and suture more accurately. Now another second suture has been placed by me, and the throws are being put. This way I'm trying to suture the perforations, and you will have a very beautiful outcome. This patient has survived very nicely. There were no post-op complication. There was no need of any secondary surgery after the process was completed. Now you can see my first perforation has been sealed. Now another, and I will leave this thread here itself. The reason why I'm leaving this thread here itself, this needle here itself, will be known to you at the end of the surgery. Here I am trying to take one more stitch because the perforation was bigger and I am seeing a bit leak from there. I will leave down the needle in the cavity itself, and my another needle will come into picture after a few seconds. I'm fast forwarding this video for that. Yeah, you can see that one needle is placed over there. I am suturing this first perforation now. And there is another needle. I have kept first needle there itself. I'm trying that needle shouldn't hurt. So I have kept it very softly over there. My suturing is going on for the second perforation. Knots and multiple throws. It's going very nicely till now. After this, I will do a thorough lavage of this site. This is because I want to make a leak test. I want to confirm there is no. You can see I'm putting saline over there and trying to see whether there was no leak. That's why I have taken, now I have decided to put the omentum, that is modified Graham's patch repair, because putting an omentum, that to a live omentum, will reduce the chances of failure of your surgery. There are two options. We can put a dead omentum patch, or we can put a live omentum patch. I have selected to go for a live because there was a good amount of omentum available, which was easily stretchable up to the perforation site. Again, I'm giving a good lavage. You can see the pelvis, it's very contaminated, very bad was the internal picture. Now the needles which I have kept there, I haven't discontinued my previous sutures. The reason was I was going to use those sutures for putting this omentum over the perforated sutured part. Now you can see that I will use the same.
Sir, voice is not clear properly.
Okay. So I'm trying to put a live omentum over the perforation site. So with this, I have done a laparoscopic modified Graham's patch repair for duodenal perforation with minimal injury to the patient. See, this is the final view of the things. You can see that the perforated site are absolutely covered, and the omentum is very nicely tucked by me. There is no other tissue being damaged, neither the liver has been injured or nothing, and the patient had a very beautiful outcome with this. Again, final lavage by me. Now I will put 2 drains in the cavity. One of the drain will be placed just in the subhepatic region, just over the perforation, and another drain will go into the pelvic cavity. Just this is, the needles are being pulled out and the surgery is over. This is how you can see a minimal access surgery helps us to give beautiful results to our patients. My next video is of umbilical hernia. We have come across such hernias, and its laparoscopical repair of umbilical hernia is a bit costly, but it is a very easy procedure, I must say. The procedure is called as IPOM, intraperitoneal onlay mesh repair. The umbilical hernias usually look like volcanoes. You can see how it was looking like. Now I'm trying to reduce the contents. The hernia has a simple go through for all hernias. You have to reduce the contents. Any hernia, it is ventral, it is inguinal. First, you need to reduce the contents. Here I am trying to reduce the contents of my hernia was just only fatty tissue.
Please switch to full screen mode.
Yeah. The contents of the hernia was just the omentum. If it would have been a bowel, then I would have taken utmost care not to cause any injury. Again, this is my vessel sealer is coming into picture. I'm trying to coagulate any minimal possible vessels which can cause a bleed, because once I have put the omentum down, I won't find out it easy to search for the vessels and coagulate them. And second thing, for hernia, we all know that when they put a foreign body into the patient's body, it is very prone to infections. And to lessen the infection, I need to minimize the blood clots within cavity. This is the hernial defect. Yes, now you can see that I have put in a mesh. So why the ventral hernias are costly? What's the reason behind the cost of ventral hernias? You can see this mesh. You can see at the end of the edges of the mesh, a fine film is visible. That is hydrophilic collagen film. This collagen film faces the bowel of the patient and reduces the chances of bowel adhesions to the mesh, because proline, the mesh is of proline, and the proline has a very bad habit to get added to the surrounding tissues. And if the bowel gets added, then the patient may have further complications. That's why in ventral hernias, in umbilical hernias, we use composite mesh or bilayered mesh, which are made of multiple absorbable materials, which are marketed by various companies, and that makes it more costly. And second thing, you can see that mesh has been hanging by me. The mesh is hanged and fixed to the patient's body with the help of screw, which are visible. Here is one of the screw. This screw, we call it as tacker. A single tacker each time at every corner helps to hold the mesh. So this tacker is also very costly, which adds to the cost of ventral hernia repair. This tacker, each screw is of material called as titanium, which is an inert material. We need not to worry whether the patient needs, in future, if the patient need to undergo CT scan or MRI, there are no interactions. It's an inert material, but it's a costly material. Now you can see that at the edges of the mesh, I'm putting the multiple trackers. One may have a thought that what's the need of putting so many tackers to fix the mesh? The basic principle of tacker is not just to hang the mesh over there. The motive is there shouldn't be any loophole. There shouldn't be any single passage through which a bowel can migrate in between the mesh and anterior abdominal wall. Because if something like that happens, it may lead to multiple complications, as if bowel obstruction or bowel necrosis, and then patient may need to undergo another surgery, which would be a threatening for that patient. This patient on whom I am operating was a 110 kg female. And you can imagine, if in such a hefty patient, if I am going for open umbilical hernia repair, the amount of fat tissue I would have to cross over to reach the peritoneal cavity, and the raw surface that would have been created due to the surgical procedure, the serosanguinous exudates that would have been created through that procedure, through that scar, and the chances of that scar getting infected and the mesh getting infected would have been on a very higher side. That's why we must say that in many aspects, in such patients, again, the minimal invasion which we are using, just 3 pinholes, is a boon for us. And the outcome is very beautiful. The patient may walk off the bed within next 10 to 12 hours. So the mesh is nicely snug on all sides. You can see that everything is fine. And now we will come out. So this is the ventral hernia. Now the next case. I am just presenting you the case of laparoscopic procedures which I do. Now the dermoid ovarian cyst. How to deal with a dermoid ovarian cyst. Dermoid ovarian cyst, we all know many of the times is called as a precursor of malignancy. So again, if the size of cyst differs, there are sometimes we encounter small cyst, or sometimes we have a large cyst. Now again, you can see the cyst, it's not much big. Now my scissor is coming into picture. I'm trying to cut the ovarian cortex. Yeah, the ovarian cortex has been breached. Now with the help of blunt dissection, I'm trying to open up. You can see the pultaceous material coming out through the cyst. Now you can see some hair follicles also there. See, we all know that the dermoid ovarian usually contains hair follicles, sometimes teeth, and the pultaceous material. Now I'm trying to create a plane in between the dermoid cyst and the ovarian cortex. And then I will easily pull off the cyst off the ovary. In dermoid ovarian cyst, we don't go for oophorectomies because the cyst is dermoid cyst is an encapsulated cyst, and we can easily dissect it off and we can preserve our ovaries. You can see that my Maryland instrument is creating a plane in between the cyst and the ovarian cortex. Again, here you can see a globe resting just next to the ovary. This is again a simple endobag that has been created by me with the help of globe. This has been placed here so that as soon as the dermoid ovarian cyst contents comes out of the cyst or the cyst comes out, I will directly place it into the endobag so as to prevent the peritoneal contamination, because we all know that dermoid cyst has a tendency, called as a precursor of malignancy. So there should be no, or at least least, contamination of the peritoneal cavity with the contents of dermoid cyst. So I'm trying to peel off the ovarian cortex with the help of my instruments, and shortly everything will go into that endobag. Here now, most of the cyst part has been removed, peeled off the ovary. The ovary is again there. You can see there is very least bleeding, and again we all know that ovary has a good tendency of bleeding also, and it has a good hemostatic tendency also. There is nothing to worry. The cyst has been removed completely, and I have put it into the endobag, and it will prevent the contamination of the cavity. Now again, see, you can see some contamination which has been done. Some things have been. Now you can see my suction coming into the picture. After that, I am trying to give a copious lavage, a good lavage, so that by chance, if any contamination has been done during the surgical procedures, that can be removed. There is no bleed from the ovary. You have seen that during the entire procedure, I haven't used the energy source in a single instant. I have not coagulated anything. This indicates that if you are following the proper planes of the surgery, you need not to worry for bleed, because it's not going to bleed at any cost. Now you can see that I am giving a wash to my endobag also. The reason is that when I'm going to pull that endobag through a small incision, I don't want the skin edges to get contaminated and patient having a surgical site infection in future. Now you can see that bag is pulled off. Now the cyst contents will be fragmented in small pieces and will be removed, and the glow bag will also come off. Surgery done, no bleed, and with least invasion and very small 1 centimeter pinhole, the complete surgery is done. My next surgical video, which is of indirect inguinal hernia. Again, we all know that we all BMS surgeons operate hernias, and they do operate it very nicely. But again, there are thoughts that what of inguinal hernias? It is direct, indirect, the amount of invasion, the size of mesh that we put while operating all differs in respect to laparoscopic hernia repair and open surgical approach. In laparoscopic approach, we put at least 4 times bigger size mesh in a person as compared when we are performing open. And the second thing, the aspect of operating laparoscopic hernia is absolute 180 degree against the open surgery. because in open surgeries, we enter from up to down, and in laparoscopic surgery, we go from down to up. Here you can see I'm trying to dissect the peritoneum. Again, I have told you in the starting itself that surgery is a skill in which you need to dissect the peritoneum. If you are dissecting the peritoneum, you are doing a proper surgery. If you are going somewhere deep, then you are ought to damage some of the vital structure and complications to happen. Now you can see just I'm on the medial aspect, just lateral to the bladder wall, and I'm going here deep, trying to dissect, trying to see the lighthouse, the Cooper's ligament or the pubic bone part. Here, this is a very old video, so the quality of the picture is not as that good, but possibly I would, there you can see a small whitish structure here where my, this is showing, my arrow is, cursor is there. That is the lighthouse. And you can see the different structures which have been dissected. The peritoneum has been pulled off by me. And this case is not just of inguinal hernia. This patient is a 50-year male who was having an undescended testis on that side. So here I'm going to do two things. I'm going to remove his testis. I'm going to perform his orchidectomy, as well I'm going to repair his left inguinal hernia. So you can see my peritoneum, I'm putting it down. That's the medial umbilical artery that can be seen. The testis is being pulled within the cavity by me. The cord structures needs to be dissected. Here in performing inguinal hernias laparoscopically, we have to keep in mind of few dangerous areas. Those are called as trapezoid of disaster. Another is called as triangle of doom. Triangle of doom indicate it's a deadly triangle in which if you are caught, the patient is going to die. So we won't be discussing in details in this video. Just here I'm trying to give the orientation of the procedures that we can do laparoscopically in such a beautiful fashion that patient has minimal damage to his body tissues, minimal scarring, and very early recovery. The testis is removed by me. This is the testis which is coming out. The specimen will be retrieved at the end. Now I'm trying to dissect the cord structures here. Fast forwarding the video. As this is a long standing, because the testes are undescended, the sac is chronic, they are very tough, dense adhesions, and I need to use energy sources a lot so that I have to dissect all the structures. Now you can see that I am creating the space for hernia mesh. The mesh, Prolene mesh will come into picture after a few seconds, and I will place here. You can see the cavity, you can see the space that I have created for the mesh to be placed in. And when we operate an inguinal hernia laparoscopically, we actually operate for three hernias. One is obturator hernia, one is femoral hernia, and one is inguinal hernia. Because when we place a huge mesh and when we are approaching through the peritoneal cavity, all three orifices, namely for obturator hernia, femoral hernia, and inguinal hernia, all the orifices are obliterated in a single surgery. So the patient is again benefited with the thing that in future he won't have any other sort of hernia recurrence. Now you can see what a bigger size of mesh I have placed inside. The vision is a bit poor in this video because this scope was not of mine. I have used some another surgeon's scope and operated for him. Now again the tacker comes into the picture. Here what I am searching for is the lighthouse, that the pubic tubercle is there. It is evident very nicely. You can see the curvature of the pubic tubercle here where my cursor is there, and I will be fixing the mesh there with the help of tacker. Yeah, the tacker is placed. I will fix the mesh with two tackers so that it is toughly fitted over there. It doesn't migrate anywhere post surgery. Now you can see that I am laying the mesh, I'm spreading the mesh, and you can see how nicely the mesh is spread over the complete dissected area. There is network issue here. Now the mesh is nicely spread, and after that I will come out. I will close the peritoneal layer which I have opened to create a space for the mesh, and the surgery will be over. Just the mesh is laid very nicely. There are no folds, nothing. Again, the Vicryl 2O Vicryl has come into picture, and again I am trying to suture the peritoneum, which I have opened for the surgery, and that's surgery is completed. So again, I must say that with a single procedure, we can operate for 10. We can operate for 3 different types of hernias. So this was the end of the surgical presentation. I have many more surgeries. Those are uploaded by me on my YouTube channel named as Dr. Pramay Dhage. You can go through those surgical procedures. And again, a platform benefit I would like to take here and would like to tell you that I have been starting a laparoscopic skill development course for surgeons and gynecologists, those who are interested to develop a surgical skill. So, and now at the end, I would like to thank the organizing committee. I would like to thank Dr. Wagesh sir, Dr. Kulkarni madam for giving me such a precious platform to show my videos and to encourage the upcoming generation from our fraternity so that they could also try to learn the advances and give better outcomes to the patient. Thank you.
I must say that this was one of the best experience of the surgical procedures that I have ever experienced, because I am from the subject of Dravigun, and it was a really wonderful experience that I could not look here and there. I was just watching this complete presentation throughout the session. I must thank you very much, my dear friend Dr. Pramay, for such a wonderful and such a innovative and all the case presentations. Thank you very much. Now I would like to request Dr. Neeraj sir to please introduce and invite our moderator of this session. Over to you, Dr. Neeraj sir.
Thank you very much. Hello, good evening, Dr. Pramay Dhage sir.
Good evening.
So thank you so much, respected Dr. Pramay Dhage sir, for the excellent, clear, and typically clinically oriented presentation. I would also feel pleasure to introduce our another moderator, respected Dr. Yogesh Badwe sir. Yogesh Badwe sir is basically head of the department from Sri Ayurved Mahavidyalaya, Nagpur. He is a very eminent surgeon with a terribly skilled hand and prosperous knowledge guiding the paths of students. I may request respected Dr. Yogesh Badwe sir to moderate the session and put your expert comments. Thank you very much, sir.
Thank you, Vichore sir. Am I audible? Am I audible? Yeah.
Yes,
okay.
Sir. Please switch on your video, sir.
Okay.
Yeah, thank you.
I am thankful to Jupiter College for giving me this opportunity as a moderator. I congratulate the organizing team of the Jupiter College Surgery Department and Dr. Wagesh sir for this excellent seminar. They have chosen the wonderful topics of very interesting topics which are the in the boom of surgery, like laparoscopic surgeries and laser surgeries. So these are now in a boom in the field of the surgery, and there are so many new innovations. But as we are as a learner and as a guide, we have to go for newer approaches and newer skills development. So here I am, and for this initiation to the by the Jupiter College, it's very wonderful, and I congratulate them. I know Dr. Pramay since many years, and he is very skilled in doing different laparoscopic surgeries. He used to come to our Pakwasa Hospital and Sri Ayurved College for laparoscopic surgeries, and he explained this topic very well. And I was thinking that some basics he should also conduct with this topic. He introduced some laparoscopic instruments, and he showed many laparoscopic surgeries like laparoscopic appendicectomy, laparoscopic cholecystectomy, tubular cyst torsion, as well as laparoscopic perforation, so laparoscopic hernias. So all these are showing his excellent skill and very good skill on. So I mean to say that he is having excellent skill in the laparoscopic surgery, and this should be converted into the teaching also. So not only by him, but our institute should take a initiation in this type of training for the laparoscopic surgeries and advances in the surgeries. So I may suggest to CCM as well as university, especially Dean Dr. Deshmukh sir is also here, and many BOS members are here, that this one should include the laparoscopic surgical training in the curriculum of PG, not only in syllabus. In syllabus it is there, but it should be as a training. It should be included as a training in a PG syllabus. It requires compulsion for the laparoscopic instruments in Ayurvedic colleges and as well as endo trainers, and also initiate the training to all the teachers for to do the laparoscopic surgeries as well as laser surgeries. So I must thank to Dr. Pramey also, and Dr. Praveen Sahave also showed very good laser hemorrhoidoplasty and all the spectrums of the proctology, like sphincterotomy as well as phalanx surgeries, spinal sinus. So all both are eminent speakers, and both are have shown a very good clinical knowledge, and they shared very good experience, and this will encourage our PGs and our practitioner to do the further advancement in their surgeries. Thank you very much. Hello.
For your words and accepting our request for being a moderator of this session.
Thank you.
Last but not the least, I must say that whenever around 15 days ago we were discussing about the theme of this complete webinar series, our respected Dr. Principal Sir just said us that all these webinars will be on practical approach with case presentation, and he personally requested all the respected guest speakers to include photos and videos. Now we understand that what is the power of practical aspect and case presentation. His vision in this regard is really very appreciable. I thank you very much, respected Bhagi Principal Sir, for conducting on specific case presentation and practical approach. I would like to thank Dr. Pramey Dhage also, my friend, for this wonderful session, respected Dr. Badwe sir also. Now, before proceedings toward the last part of this session, I have a few announcements for all the participants, that if you have any queries related to both the sessions, our guests are here only, you can put your questions in the chat box, or you can directly switch on your mic so that they can answer your queries, the part of question answer session. Participant, if you have any query, you can surely ask. All the participants, those who want to join the trainings by all these guests, Dr. Sahave sir and Dr. Pramey Dhage sir, you can surely contact them for their various training programs. They are really very helpful. The next part of announcement is that we will be sharing a feedback form, that you will receive the feedback form by tomorrow morning through the email. I request all the participants to please submit that feedback form, and within 2 to 3 days, you will receive your e-certificate of participation through email only. So this was all about announcement. Now moving toward the last part of the session, I would like to request Dr. Gechode sir to please start with the vote of thanks. Over to you, Dr. Neeraj sir.
Thank you, sir. So, good evening, everyone. It was an absolute mesmerizing session, couple of sessions in front of us by respected Dr. Praveen Save sir and Dr. Pramay Dhage sir. After that, I would like to start my vote of thanks. Honorable Dr. Ashutosh Gupta sir, President of MCIM, respected Dr. Shrikant Deshmukh sir, Faculty Dean of Ayurveda, MEHS Nashik, respected Dr. Mahendra Agarwal sir, BOS, MEHS Nashik, respected Mrs. Tarini Nikhare ma'am, Secretary of Gurudas Shikshan Sanstha, respected Dr. Subhash Waghe sir, Principal of Jupiter Ayurved Medical College and Hospital, Nagpur, our most valued invited guests, ladies and gentlemen. It's my privilege to have been asked to propose a vote of thanks on this occasion. I, on behalf of Jupiter Ayurved Medical College and Hospital, Nagpur, MCIM and MEHS Nashik, let me call it fraternity of field of Shalya tantra here together. And on my own behalf, extend a very hearty vote of thanks to all speakers for gracing your important work and sharing with us your findings and opinions today. A big thank you to Dr. Praveen Save sir for his effort towards role of laser therapy in the management of proctology disorder. Dr. Praveen Save sir is one of the finest coloproctologists across India, updated with many modern technologies. I must mention our deep sense of appreciation for Dr. Pramay Dhage sir for his explanation of laparoscopic interventions in surgical disorders. Dr. Pramay Dhage sir is the most appreciated young laparoscopic surgeon with the tremendous and updated knowledge in the fraternity of surgery. We are all inspired by your great work, sir. Finally, I would like to take this opportunity to place on record our hearty thanks to Honorable Dr. Ashutosh Gupta sir, President of MCIM, respected Dr. Shrikant Deshmukh sir, Faculty Dean of Ayurveda, MEHS Nashik, for the perfect logistic support and guidance they have extended to all of us at this webinar, and respected Dr. Mahendra Agarwal sir, BOS, MEHS, for observing this webinar. I also extend my thanks to respected Mrs. Tarini Nikhare ma'am, Secretary of Gurudas Shikshan Sanstha, and also to respected Dr. Subhash Waghe sir, Principal of Jupiter Ayurved Medical College and Hospital, Nagpur, for their enormous cooperation in the organization of this event. I also extend my thanks to respected Dr. S.K. Danga sir, Vice Principal of Jupiter Ayurved Medical College, respected Dr. Shrikant Hadole sir, Organizing Secretary of this webinar, respected Dr. Veena Kulkarni ma'am, Professor and Head of the Department of Shalya Tantra Department, my young and energetic colleague in the department, Dr. Avinash Bharti, for the tremendous cooperation and guidance in the organization of this event. Well, Mr. Chairman, ladies and gentlemen, an event like this cannot happen overnight. The wheels start rolling weeks ago. It requires planning and a bird eye for details. We have been fortunate enough to be backed by a team of very motivated and dedicated colleagues of Jupiter Ayurved Medical College, Nagpur, who know their job and result oriented. I cannot thank everyone enough for their involvement and their willingness to take on the completion of tasks beyond their comfort zone. Thank you so much, everyone, for your attendance to this event in spite of your busy schedule. Thank you very much.
Thank you very much, sir. So here we conclude today's session. I wish you all a very good day, and I wish you all to, I request all to join our further sessions, which are going to be conducted in the coming days. That means we on Shalya tantra, Bal Rog, Stri Rog, as well as Nidan. Thank you very much, all of you. Good day.
Just leave everyone. Leave.
How to fill feedback?
बॉल पेन है